Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
So there were a couple of differences in our highlights and changes in the new ART guidelines that were updated at the end of December of 19, and I'm going to focus on a 2-drug regimen for initial therapy, as some of you may have noticed in the guidelines. So I wanted to start off with a question. So a 29-year-old man with newly diagnosed HIV, no comorbidities, he's not on any other medications. Would you offer him a 2-drug regimen for treatment? 2 early adopters here of new guidelines. Otherwise, half of you know, and then some of you, it depends. So
one thing to clarify, Tricia, this, just to be clear, this would be first ever ART, right?
That's right.
Initial therapy, not a switch, no prior history of ART.
That's right. Newly diagnosed, never been on treatment. You don't know what his adherence is going to be like because he's never been on medications. But I wanted to just highlight what stayed the same. So these are not the new regimens that you see here. So as we know that we've moved towards Integrace, INSTIs as our anchor medication, as our preferred for most patients who are starting initial regimens with 2 nukes, preferably a TDF or TAF 3TC, or a Bacavir if you're going to get HLA testing as well. So raltegravir is still on this, on the HHS guidelines, but you will note that an IAS, I think it is no longer at the initial regimen. So depending on which guidelines you're looking at, that raltegravir may or may not be in the same preferred as initial therapy. So what's new is the new recommendation is that you can start an integrase inhibitor with 1 NRTI. However, the only one that has been studied in terms of the combination is dolutegravir plus 3TC, and it's an A1 recommendation, meaning that the panel felt like it was a strong recommendation and the level of evidence is strong level of evidence, which we'll go through. So it's interesting that it's in this box because there is another box for considerations or special considerations for initial therapy. And even though there's special considerations for this therapy, it's not in that other box. And so here are the special considerations. You would not consider this dual regimen therapy in individuals with very high viral loads greater than 500,000 or Hep B co-infection, and mainly because then you'd be just treating with 3TC monotherapy. As we know, TDF or TAF have activity against Hep B. And those in whom you want to start ART before the results of genotype testing are back. Literally right above this section of what's new in the guidelines is a section that says when to start, and it says as soon as possible, and maybe even same day. So it's interesting that this caveat is in the guidelines. If you're waiting at all, if you're not waiting for resistance testing, then this is not really a potential option. So I wanted to go into the rationale for the 2-drug regimen as initial therapy, since this was considered level 1 evidence. So go through it historically. The paddle study was the first study that was published in 2017 that was just a pilot study, 20 patients, ART naive, but they excluded patients with viral loads greater than 100,000. So not 500,000, but 100,000, or any baseline resistance. 2 out of the 20 didn't achieve suppression. 1 was felt to be unrelated. And 1 had a baseline viral load of about 100, just over 100,000, and did not suppress over time. That led to the phase 2 study. I think Brian has reviewed these studies in the past, which had an N of 120 of treatment-naive patients, viral loads between 1,000 and 500,000. Again, no baseline resistance, 85% achieving virologic suppression at 48 weeks. At 24-week endpoint, it was actually 90% suppression. So it did go down at the 48-week mark compared to the 24-week endpoint mark. One patient developed an M184V and an integrase mutation who had virologic failure. So that was a potential concern. Brian kindly gave these slides for Gemini, which he's reviewed before, and these are the larger phase 3 studies that looked at looking at dolutegravir 3TC versus dolutegravir with TDF-FTC as initial therapy. And these were randomized, double-blind, multinational trials that really looked to compare these regimens for the 3TC DTG regimen to see if it was non-inferior to the triple therapy. Again, these patients were treatment-naive individuals, viral loads below 500,000, no mutations to NRTIs, INSTIs, or PI, no major PI mutations, not chronically Hep B infected, as I mentioned before, did not need Hep C therapy, and were not pregnant or breastfeeding. Again, the primary endpoint, they looked at 48-week and 96-week data, was percent who are virologically suppressed. And obviously they had much larger numbers than those initial studies. Baseline characteristics are here, with most patients having a viral load less than 100,000, only of 20% of each arm having a viral load greater than 100,000. So that's important to note, given that the guidelines actually say less than 500,000 is okay. So let's look at the 96-week data, and this is again courtesy of Brian. And you can see the results here, even when compared by baseline viral load, the percent who achieved virologic suppression were fairly similar. So 87 to 90% if you're less than 100,000, and 84 to 86% if you're greater than 100,000. So achieve that non-inferiority. Interestingly, I'd like to point out here that when you stratify by baseline CD4 count of less than 200 versus greater than 200, there is a difference here, 68 to 87% virologic suppression. And the pooled data, however, did not show a statistical difference, and that's important to note. And as I mentioned in the guidelines, there's no stratification based and decision-making point based on CD4 count that they outline. It's just based on viral load of greater than 500,000 that you shouldn't use the dual therapy. So the conclusion, again, this is courtesy of Brian, that it was non-inferior without risk of treatment-emergent resistance. And I didn't show the data, but there was actually no significant difference in toxicity either that supported the use of DTG and 3TC as initial therapy.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.